Today we're gonna talk about sarcoidosis. Sarcoidosis, we have symptoms related to the lung, skin, eyes, peripheral nerves, liver, kidney, heart, and other tissues. Demonstration of non-caseating granulomas in a biopsy specimen, and we have also to exclude other causes of granulomatous disorders. Sarcoidosis is a systemic disease of unknown etiology characterized in about 90% of patients by granulomatous inflammations of the lung. The incidence is highest in North American blacks and Northern European whites. Among blacks, women are more frequently affected than men. Onset of disease is usually in the third or fourth decade. How to diagnose sarcoidosis? Clinical findings. Signs and symptoms of sarcoidosis. Patients may present with malaise, fever, and dyspnea of insidious onset. Symptoms referable to the skin, eyes, peripheral nerves, liver, kidney, or heart may also cause the patient to seek care. Some individuals are asymptomatic and come to medical attention after abnormal findings, typically bilateral hilar and right paratracheal lymphadenopathy on chest radiographs. Physical findings are atypical of interstitial lung disease. Freckles are uncommon on chest examination. Other findings may include erythema nodosum, parotid gland enlargement, hepatosplenomegaly, and lymphadenopathy. Laboratory findings. Laboratory tests may show leukopenia, an elevated erythrocyte sedimentation rate, and hypercalcemia about 5% of patients, or hypercalciuria 20% of patients. Angiotensin converting enzyme ACE levels are elevated in 40 to 80% of patients with active disease. This finding is neither sensitive nor specific enough to have diagnostic significance. Physiologic testing may reveal evidence of airflow obstruction, but restrictive changes with decreased lung volumes and diffusing capacity are more common. Skin test energy is present in 70% of patients. ECG may show also conduction disturbances and dysarrhythmias. Imaging. Radiographic findings are variable and include bilateral hilar adenopathy alone in radiographic stage 1, hilar adenopathy and parenchymal involvement in radiographic stage 2, or parenchymal involvement alone in radiographic stage 3. Parenchymal involvement is usually manifested radiographically by diffused reticular infiltrates, but focal infiltrates, acinar shadows, nodules, and rarely cavitation can be seen. Pleural effusion is noted in fewer than 10% of patients. The diagnosis of sarcoidosis generally requires the histopathologic demonstration of non-caseating granulomas in biopsies from a patient with other typical associated manifestations. Other granulomatous diseases, for example, berylliosis, tuberculosis, and fungal infections, and lymphoma must be also excluded. Biopsy of easily accessible sites, that's to say palpable lymph nodes, skin lesions, or salivary glands, is likely to be positive. Transbronchial lung biopsy has a high yield, about 75 to 90% as well, especially in patients with radiographic evidence of parenchymal involvement. Some clinicians believe that tissue biopsy is not necessary when stage 1 radiographic findings are detected in a clinical situation. That strongly favors the diagnosis of sarcoidosis. For example, A young black woman with erythema nodosum. Biopsy is essential whenever clinical and radiographic findings suggest the possibility of an alternative diagnosis such as lymphoma. Bronchoalveolar lavage fluid in sarcoidosis is usually characterized by an increase in lymphocytes and a high CD4 to CD8 cell ratio. Bronchoalveolar lavage does not establish a diagnosis but may be useful in following the activity of sarcoidosis in selected patients. All patients require a complete ophthalmological evaluation. Treatment. Indication for treatment with oral corticosteroids such as prednisone 0.5 to 1 mg per kilogram per day include disabling constitutional symptoms, hypercalcemia, iritis, uveitis, arthritis, central nervous system involvement, cardiac involvement, granulomatous hepatitis, cutaneous lesions other than erythema nodosum, and progressive pulmonary lesions. Long-term therapy is usually required over months to years. Serum ACE levels usually fall with clinical improvement. Immunosuppressive drugs and cyclosporin have been tried, primarily when corticosteroid therapy has been exhausted, but experience with these drugs is limited. Anti-tumor necrosis factor (TNF) therapy with infliximab also has shown some promise in extrapulmonary sarcoidosis. Prognosis. The outlook is best for patients with hilar adenopathy alone. Radiographic involvement of the lung parenchyma is associated with a worse prognosis. Erythema nodosum presents a good outcome. About 20% of patients with lung involvement suffer irreversible lung impairment characterized by progressive fibrosis, bronchiectasis, and cavitation. Pneumothorax, hemoptysis, mycetoma, formation in lung cavities, and respiratory failure often complicate this advanced stage. Myocardial sarcoidosis occurs in about 5% of patients, sometimes leading to restrictive cardiomyopathy, cardiac dysrhythmias, and conduction disturbances. Death from pulmonary insufficiency occurs in about 5% of patients. Patients require long-term follow-up, at a minimum, yearly physical examination, pulmonary function tests, chemistry panel, ophthalmological evaluation, chest radiograph, and ECG. Thank you.